Thank you for this opportunity. It's quite an august audience and august chairpersons here. And this is essentially going to be a little bit faster than I would have liked, but let's try and see if we can encompass what can be seen on an ECG, which can predict a sudden cardiac arrest. So that's why I've given it sudden cardiac arrest, because predictors of sudden cardiac death is a little bit challenging and essentially depends on how good or what CPR availability is there wherever that event happens. So the objectives of my talk are essentially, what is the problem statement? Why are we even worried about it? Is ejection fraction really the predictor? What are the markers for cardiomyopathies and channelopathies? What repolarization abnormalities are present? Increasingly, there is a very high role for data analysis, and I'll come to that towards the end of my talk. And how can we integrate data analysis into our day-to-day workflow? So this is the problem statement. The incidence and total events, we already know in the high-risk population is very high. Ejection fraction less than 30%, cardiac arrest survivor, arrhythmia risk markers, post-myocardial infarction group. That's a very high group of people at risk for sudden cardiac arrest. But the absolute number, because of the huge population of the country, is actually in the general population, and that's where it causes a problem and a public health issue. In a large city in India, across the city, there is one sudden cardiac arrest every 15 minutes. And that remains the magnitude of this issue. Ejection fraction is something that we commonly use. It's used to inform the guidelines for implantation of a primary prevention ICD. And all of us in the field know it's a very poor marker in terms of its sensitivity. The specificity is good, the sensitivity is very poor. You really can't pick up too many patients. So we've got additional ideas like inducible VT, patient enrolled as inpatient, NSVT not discovered 10 days after CABG, IVCD left bundle branch block. But these are not really very, very specific to take any action for that patient. So we're not really doing very well. If you look at the MUST trial, the ICD actually helped you, but it's a very specific chosen group of patients. What do we do about the public health issue? And if you look at this article by Marwick et al. In 2018, they question the very fact as to when to trust and when to distrust ejection fraction as a reason to evaluate for sudden cardiac arrest possibility. ECG is and has been the only easily scalable, recordable biosignal. By human experience, when we look at the ECG, there are some pattern recognitions we have that depends and tells us that there can be a high chance of sudden cardiac arrest. It includes QRS duration, QRS fragmentation, increasing voltage, decreasing voltage. So anything on that ECG that is not normal is probably a risk factor for sudden cardiac arrest. So are we going to really put ICDs into everybody for primary prevention, or keep them at home, or make them wear a wearable defibrillator? Not really. But having said that, one of the largest contributors to an episode of sudden cardiac arrest is ischemia of the myocardium and its sequelae. So we have the ECG changes following reduction in myocardial blood supply, as you know, with the Skalowski-Birnbaum scaling. Then you have the resolution of that ischemia with infarction and the subsequent changes that you will see. The ST elevations, the Q waves, the loss of R wave magnitude. And finally, not to forget the remodeling and the persistence of ST elevation across the precordium, suggesting that there is perhaps aneurysmal changes which can predispose to electrical abnormalities. Going from ischemia to something that is more common is an alternate way to activate the myocardium, namely good old WPW, or an accessory pathway. It is a rare occurrence, but it's a well-described occurrence. Then you do have left ventricular hypertrophy with the strain pattern. Always be concerned when the repolarization already changes. Always question, why is the repolarization changing? because the depolarization is directly proportional to the myocardial muscle mass and the quality of the myocardium, but the repolarization changing indicates there's something else that is going on, and there is a change in the way the myocardium is repolarizing. The variability in that, as we shall see in the repolarization disorders, is what can predispose to ventricular fibrillation. And here, unlike the ischemic scar VT subgroup, it is not monomorphic. It is polymorphic and ventricular fibrillation rather than the monomorphic VT who might walk into the ER. So, left ventricular hypertrophy and its close friend, hypertrophic cardiomyopathy. A left ventricular hypertrophy without the repolarization change is a more problematic thing than a left ventricular hypertrophy with a repolarization change. So, what are you worried about? You are worried about the fact that these patients are going to have either a genetic or a non-genetic cause of increased muscle mass, fibrosis, which in turn can lead to a problem. When we see STT changes, repolarization changes, what we are concerned about is the fact, is it ischemia? And differences from ischemia essentially are at the ST segment, where there is a current of injury pushing that ST segment up, upcoving it, and thereby allowing us to suspect ischemia as compared to a non-ischemic cause of STT changes. Furthermore, a big predictor of this particular problem is the fragmentation on the ECG. The ECG should be sleek. It should be like a highway. Any change, any zigzag, any kind of fragmentation on it suggests some amount of scar. And for those of you interested in vectorcardiography, if you can look at where that scar is in terms of its axis, just like you do a QRS axis, a lot of times you can pinpoint with good accuracy where the scar is. Remember, the precordial leads are all unipolar leads. So when the activation wavefront is going away from you, you can actually guess where it could be. So if you look at that ECG, it's a little bit challenging, but you can look at the axis of the fragmentation there, giving you a sense of where it could be. Complete change in the way the myocardium is activated, instead of it being on both sides, on the free wall and the septum near simultaneously, it is going sequentially. It's not parallel, but in series, namely the bundle branch block, more for the left bundle branch block as compared to the right bundle branch block. But here is a kicker, both of them are bad. And a lot of times in non-ischemic cardiomyopathy, you have what is called an IVCD kind of a morphology, which is more dangerous in terms of the possibility of sudden cardiac arrest. Now, if you compare this ECG, which is a left bundle branch block, with this ECG, which has a left bundle branch block, but also has fragmentation. So it's not purely an electrical problem. There is a myocardial involvement also associated with it, which makes you more scared as to the propensity to develop a sudden cardiac arrest episode. Now look at this ECG, again a left bundle branch block. But there is something funny, right? Hardly any Q waves, hardly any R waves across the precordium. It's only the last V5, V6 that you're seeing it. So a left bundle branch block morphology, monomorphic VT, you want to see the sinus rhythm ECG, and you look at this terminal depolarization and fragmentation, which is suggestive of ARVC, one of the other causes of having some kind of an event predisposing to sudden cardiac arrest. One uncommon but real cause, especially in the younger people, is this condition called mitral valve prolapse. All of us who do echoes know mitral valve prolapse as this really irritating problem where the patient always has palpitations, come in, doesn't get an ECG that is abnormal. We keep on reassuring them. But what is important is to look at the factors in mitral valve prolapse that can predispose to sudden cardiac arrest, and the suspicion starts from the ECG, where you have T-wave inversion in the inferior leads. On a Holter, you have complex ventricular ectopy consisting of both outflow tract PVCs or non-sustained VT along with inflow tract in the left ventricle, non-sustained VT or PVCs. This is called the malignant phenotype and is a worrisome predictor on an ECG for the possibility of a sudden cardiac arrest. It should prompt a workup, namely for scarring, mitral annular disjunction, and possible genetic abnormalities for predisposing to mitral valve prolapse and its complications. So you have the arrhythmia severity score that was given out for the mitral valve prolapse series, and as the arrhythmia severity increases, so does the possibility that you have high mortality. And given that this is a very young group of patients we are talking, it assumes greater significance. Going on from there, sometimes, and this was very common when we had the COVID epidemic, you have myocarditis with a fever, and that fever actually causes fascicular ectopy. Look at the extra beats there on the ECG, and you can see how sleek they are. Those are fascicular PVCs and can predispose patients to have an episode. Another favorite one, mainly in exams, is the bidirectional tachycardia, where the baseline ECG shows you some PVCs. You start exercising, you start seeing abnormal events. You do not have to wait till the tachycardia happens for it to be diagnosed. In non-outflow tract bigeminy on exercise testing should alert you to this possibility. Bradycardia itself. This, as you can see, is a patient with an SVT given adenosine. See what bradycardia does to the entire situation. It actually predisposes to a phase 4 reentrant arrhythmia, namely a ventricular fibrillation kind of an event, and if not managed, can lead to abnormalities. So none of your CHBs or high-grade AV blocks should actually go home saying, oh, you can do the pacemaker later. You actually need to do it there. That's why this can happen in these patients, even at sleep. Your heart rate drops a lot during sleep. You have sinus pauses. You have obstructive sleep apnea. You don't want to treat the sinus pause with a pacemaker, but you want to treat the obstructive sleep apnea. This is what can happen when you have prolonged bradycardia. This is what I like to call the fifth vital. Temperature, pulse, BP, and respiration are all our favorites because they indicate that the patient might die soon. QT is the fifth vital. Any of us treating any of our patients needs to know what the QT of that patient is. And measurement of it is the most commonly made mistake. You have to look at the tangent to the baseline and evaluate it there. You may want to actually look at a biphasic T wave and look at where to measure it. You need not actually go to the end of that complex, but actually to the tangent to the baseline where the slope is the maximum. QT prolongation is something that happens commonly, can happen because of drug-drug interactions, can happen because of electrolyte abnormalities, and should be looked for very commonly. Sometimes when we are looking at QT prolongation and there is an arrhythmia going on, we can have this phenomenon where the QT has lability. And if you see that with tachycardia, it's a higher marker that that patient may have an earlier event. Looking at Holters for QT analysis, look at the second part of that. QT analysis can help you make the difference, especially when the baseline ECG does not show a QT abnormality. It can tell us that, look, this patient is reaching QTs which are higher, 500 or so, intermittently. Remember, the QT is an autonomic dependent variable number. It is not dependent on the 10-second ECG that we keep taking. Some intangible things like heart rate variability, T wave onset to T peak, these are some things we have looked at, but clinically has been a challenge. If you have a high suspicion of an event or a channelopathy, you should always provoke to see if there is something there. The epinephrine tests are great for LQT. Then you have the isoproterenol tests for the Brugada syndromes. You have the combination that can look at J-wave syndromes. CPVT does well for a burst exercise testing. And the J-wave syndrome, which is very common in our part of the world, is also very transient. Commonly seen with that small hunch as the Brugada. In the inferior leads is called early repolarization. and it's supposed to be some kind of a myocarditis that happens in the inferobasal septum or the outflow tract that decides what this is. You can look at VT or VF that can happen with these patients, and there is no good way to risk stratify them. These are the differentials for the J-wave syndromes and should be carefully looked at and not given ICDs at the slightest hint. Going on from there, I told you I'd promised to show you something that is not really an ECG phenomenon, but a cumulative logic of data analysis. And that is by taking a single 10-second ECG, take 1 million of them, assign them some ejection fraction below or above 50%, and give the 1,000,001 ECG, it will probably tell you whether that ejection fraction is normal or not. It also has predictive capability. In our data series, we were able to show that if the AI algorithm gave it as abnormal, within 30 days, your ejection fraction would actually drop. Going on from there, take this algorithm and put it onto a stethoscope, and you get what is a stet-based AI output consisting of rhythm analysis, murmur analysis, and plus or minus ejection fraction. So instead of making you learn everything, let us try and democratize the process completely and use it in novel ways where we can try and predict even postpartum cardiomyopathy using these novel techniques. We took that concept ahead and put it further on to diagnose coronary artery disease, presence or absence, using a single 10-second ECG. Gaidesasi et al. Used it to diagnose QT interval prolongation, even when the baseline 10-second ECG showed in normal QT interval. Now going on from there, imagine figuring out what your vascular age is using these algorithms and use it to predict cardiac transplantation outcomes, whether or not they are going to take. PVCs that we see commonly, and we know that it can lead to sudden cardiac arrest or cardiomyopathy. Which of those PVCs are actually going to do that? And what part on the ECG? Again, helping us understand that it is not actually the QRS, but actually the PR interval and the P wave that determines whether cardiomyopathy is going to happen. Kumar Narayanan and his group showed the prediction of ventricular arrhythmias from 14-day Holter tracings and showed that saliency mapping again confirmed what we already know. PVC burden, QRS fragmentation, and early depolarization are actually predictors of ventricular tachycardia. There is a bunch of algorithms available these days, including my favorite one, AF off of a sinus rhythm ECG, prediction of atrial fibrillation, and it probably has great value in using these in our day-to-day workflow, where a single ECG, just like the blood that we send to the labs, comes out with 15 or 20 probabilities, and then we learn how to use it to help our patients better. Having said all of this, let me leave you with a thought. Look at that guy. If it was a vaccine thing, everyone in blue is vaccinated, that guy is vaccinated from that disease, right? So what if 70% of this room actually knew CPR? The 30% would be protected against CPR. And that essentially is the only way to protect oneself from sudden cardiac arrest. Dr. Anita Borges passed away 3 days ago in the midst of a conference full of doctors. She had sudden cardiac arrest. So let me leave you with this really frightening thought that unless you train people for CPR and participate in the management and prevention and prediction of sudden cardiac arrest, one of us could be the next. So in summary, ECG is the most easily recorded biosignal from time immemorial. It's a global view of cardiac health that we need to take. ECG provides that. We have what is human experience derived sudden cardiac arrest markers. Data-driven markers are coming up. We need to see beyond the veil of human experience and democratize screening. It should not and cannot need a cardiologist or even an MD physician to diagnose markers for sudden cardiac arrest. It has to be every healthcare professional. And finally, we have to analyze and validate the clinical applications of these newer technology. Thank you.